Welcome to day 2 of the ASHI Sensitization in Transplantation Assessment of Risk Working Group 2025 Reports and Planning webinar series. Today's final session will feature presentations and discussions on emerging diagnostics, donor-derived cell-free DNA update, and the potential role of innate allorecognition in kidney allograft damage. Attendees are encouraged to share their questions and feedback as the group plans for a pre-meeting event at AST's Cutting Edge of Transplantation 2025 meeting. STAR working group projects have been proudly supported by AST, ASHI, Mark Tarasaki, One Lambda, a brand of Thermo Fisher, and Imokar Werfen. In a moment, I will turn the session over to our moderators, Dr. Carrie Schinstock, Professor of Medicine at the Mayo Clinic, and Dr. Anat Tambur, Research Professor of Surgery, Organ Transplantation at Northwestern University. Before we begin the main presentation, though, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded, and the archive of both webinars will be available approximately 1 week after the live sessions. Attendees are encouraged to participate today as noted, but please note that your lines have all been muted so that only the panelists can be heard clearly live and for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A button in your Zoom webinar panel. Questions submitted via chat may be missed during the presentation. It is now my pleasure to turn the session over to our moderators, Dr. Schinstock and Tambur, to begin our presentation.
Hello, everyone. My name is Anat Tambur. I'm the founder of STAR and extremely proud to have this great group joining today. I hope many of you were able to listen to our session from Tuesday. And if not, as Brian had said, those will be available later on online. I'm joined with by my co-moderator and the co-chair of STAR 2025, Dr. Carrie Schinstock. I do want to highlight again our acknowledgments to all the supporters of the STAR process, the American Society of Transplantation and the American Society of Histocompatibility and Immunogenetics. Special thanks to Mark Tarasaki, who had been supporting us from the very beginning. And then our two commercial partners, Thermo Fisher and One Lambda, and Werfen with life codes. For those of you who had listened on Tuesday, you may remember that we have two components of STAR that had wet lab parts, and we really are grateful for those commercial entities for supporting us with the reagents for this. And with that, other than thanking all the STAR working group members, I want to have special thank yous for the lab participants that had volunteered their time to perform those topics. At this point, I will hand the microphone to my co-moderator, Carrie.
Thanks, Anat. And thank you to all who've joined us for these exciting webinars today. I'm first going to introduce Nicole Valenzuela, PhD. She is from NorDX at Maine Health, and the title of her presentation is Emerging Diagnostics, Donor-Derived Cell-Free DNA. I look forward to her presentation and the exciting question and answer section afterwards. So as Brian mentioned, if you have questions that come up, please put them in the question and answer, and we'll go through those afterwards. So let's get started.
Thank you, Carrie. Good morning and good afternoon, everyone. I will kick off today's webinar with a presentation from STAR's working group on donor-derived cell-free DNA, which is the first year that we are doing this. I can advance slides. This is my conflict of interest. Nothing I will discuss is going to be affected by this. So given the anticipation for this topic and the enthusiasm, what I wanted to do was first introduce our group objective and the scope of what we worked on for this particular term. I'm going to start out with what we are not going to address, just to lay out expectations. In 2025, STAR will not be making an assessment of the clinical utility, context of use, actionability of results, or any recommendations for intervention regarding donor-derived cell-free DNA. Several transplantation societies have already issued position and consensus statements on the clinical validity of these assays, and the local coverage determination from MolDX also provides indications of use and coverage. So what we are going to be doing is stepping back, similar to what the non-HLA and antibody quantitation groups of STAR have done, to really define guidelines and gaps for analytic validity of this assay. And in particular, what we were working on was to identify factors that could influence the indication for use, clinical interpretation, or reliability of the test. And all of that will translate eventually to assessment of clinical utility. I would be remiss if I didn't acknowledge the efforts of our working group. All of the members are shown here. I'm simply presenting on their behalf, but we have representation across diverse fields, including HLA laboratory directors, particularly people who have on-the-ground experience implementing these assays in the laboratory, oversight from transplant pathology, and also one of our members has leadership experience in quality assurance and proficiency testing at the national level in the lab. We also have several transplant physicians from nephrology and thoracic transplantation. So thank you to everyone who's listed here. So cell-free DNA as a biological molecule is a normal molecule that is present in all of us, including healthy individuals, in many bodily fluids, including blood and urine. Several studies of healthy host cell-free DNA have identified that the majority of cell-free DNA in blood is leukocyte or hematopoietic in origin, especially coming from granulocytes. Outside of the blood cell compartment, the highest contribution to cell-free DNA is coming from the liver, specifically from hepatocytes. And there's a small component also from vascular endothelial cells. Cell-free DNA is released under natural cell death, especially apoptosis. And then under conditions of tissue injury, it can be released under other processes of cell death like necrosis. Its normal values range from 1 to 10 nanograms per mil in the plasma, and there are several mechanisms of clearance of cell-free DNA. So one computational study estimated that only 10% of cell-free DNA that's generated by tissue turnover actually reaches the blood. And cell-free DNA in the blood is pretty rapidly cleared, particularly through the liver, with some minor component of passive filtration through the kidneys as well. This results in quite a short half-life of cell-free DNA in the blood, typically minutes, but usually less than 2 hours, which makes it really a real-time biomarker. In addition to its clearance, cell-free DNA fluctuates over time, and this has been reported under a surprisingly wide variety of physiological conditions that are not disease-related. It also has substantial inter-individual variability, up to 30%, and within subject variability, up to 25% with repeated sampling. In addition to normal fluctuations with exercise and time of day, cell-free DNA also has been shown to fluctuate associated with systemic disease like lupus or cancer. So because of this potential for real-time assessment as a biomarker of tissue injury, cell-free DNA has been leveraged as in several clinical modalities. Here, the ones I'm going to discuss really are taking advantage of the fact that certain tissues or targets of interest have distinct genetics, and those can be measured, specifically fetal derived cell-free DNA, tumor-derived cell-free DNA, and donor allograft-derived cell-free DNA. So I wanted to briefly review the lessons from these other clinical modalities because our group read this literature and we actually learned a lot about conditions that may render the measurements unreliable, and also just logistical considerations, especially trying to establish external quality assurance and proficiency testing programs. So probably the most widely used measurement of cell-free DNA is in non-invasive prenatal testing. It is mostly qualitative, in which the presence of chromosomal abnormalities and fetal sex are determined in fetal-derived cell-free DNA. It's important to note that in this field, this test is considered non-diagnostic. So a positive result for fetal aneuploidy requires confirmation with invasive testing. The test can also be quantitative, where it provides an estimation of fetal fraction, fetal-derived cell-free DNA among total or maternal-derived cell-free DNA. And the level or abundance of fetal cell-free DNA has been associated with gestational age and potentially prognostic of adverse pregnancy outcomes. Less established field, but still exploding in terms of its application, is detection of circulating tumor DNA. Here, again, a qualitative application of this is to detect specific somatic variants in the tumor. But when applied quantitatively, it does provide an estimation of total tumor burden. And this level of the tumor burden from the quantitative result has been shown to be have the potential for prognostic value in terms of how much tumor is present, but also in response to treatment when the patients are monitored serially before intervention and after. So in this example, this model here shows that after intervention, the tumor burden declines, but then rebounds, suggesting that there's a recurrence of cancer. So donor-derived cell-free DNA then is detecting cell-free DNA that's coming specifically from the allograft, which is genetically disparate in most cases. So detection of donor-derived cell-free DNA has been associated with allograft injury, including subclinical injury, because it appears to rise earlier than typical clinical indicators of graft function like creatinine or BNP. It has also been associated with abnormal histopathological findings, which confirms that it is elevated in the presence of allograft injury. And it's been suggested that it can indicate subclinical rejection or be used to assess response to anti-rejection intervention, similar to the model that I showed for tumor-derived cell-free DNA. Unlike those other two clinical modalities, it can't be qualitative. Donor-derived cell-free DNA is inherently quantitative. And here too, an exceedingly lower limit of quantitation is required, as some reported thresholds for an abnormal response can be 0.5% or even lower. Some other important differences is that repeated testing per transplant patient is likely, unlike NIPT, in which one test is sufficient to reach a conclusion. And what I'll focus on today is that there are many interventions and clinical states that are common in transplantation that can actually impact the analyte values and thus the reliability of the results. So I'll just briefly mention this overview here, that there are a variety of methodological approaches to measuring donor-derived cell-free DNA. These have differential sensitivity, specifically variation in how many different genetic markers are measured in order to deconvolute the donor and the recipient. Most relevant to today's talk, there are also different measures of quantitation. So the value that you get on the clinical report might be different depending on the modality that's used. All methods will provide a fraction of donor-derived cell-free DNA as a % of the total cell-free DNA. And some methods also provide an absolute quantitation or concentration of copies per mil. And there are various pros and cons to each of these measures. So this table summarizes the current landscape of available testing, which to date has been limited to tests that are performed in a centralized vendor laboratory. Overall, you can see that each of these centralized tests varies slightly in terms of its methodological approach. But importantly, what I want to emphasize here is that each vendor also provides recommended thresholds for abnormal results, which are first organ-specific and second different from vendor to vendor. More recently, the vendors have started offering distributed kits, which are meant to be taken by a local laboratory so that the assay can be implemented there. This is obviously very exciting and has many advantages, especially from the HLA laboratory's perspective. We have the experience and the equipment to do all of these tests, but we also have the patient history and associated biomarkers of risk like DSA. So it would be really valuable to have these values integrated into that set of clinical history. At this point, these kits are RUO, research use only, and therefore the thresholds are not provided by the vendors. So what that means is it leaves the local laboratory up to determine certain performance specifications. And the ones that I want to talk about are the performance specifications that go into determining reference ranges and cutoffs. So there are numerous pre-analytic and analytic considerations that can affect the sensitivity of the assay and the reliability of its results. I will not discuss these in detail, but they are being prepared by STAR in our written guidance. And just this fall, our professional society, ASHI, actually adopted new standards for accreditation that are specific to donor-derived cell-free DNA. And these are pretty granular with respect to specimen processing and handling and other very technical components. So I won't go into that today in the interest of time, but these are forthcoming in written guidance. What I do want to talk about is thinking about reference ranges and normal and abnormal cutoffs that are appropriate for our patient populations. So as I mentioned, host cell-free DNA is variable under normal circumstances. And this has been described for healthy individuals where there is both inter-individual from line to line and intra-individual variation in the abundance of cell-free DNA. So this variance can be upwards of 30%. And this has an implication when we're thinking about whether it's appropriate to determine a universal threshold, which could be used for one-off or for-cause testing, or whether we really need to consider serial monitoring so that we can determine individual reference change values or a change over time from some stable baseline. This degree of normal biological variation has also been demonstrated for donor-derived cell-free DNA, and specifically our group focused on sub-analyses of some of the major clinical validation studies where they focused on the reference populations. So this is a graph from DART, which looked at about 90 stable renal transplant patients. And these are the patients they used to determine their reference population. And what you can see is that repeated measuring of individuals results in a large degree of variation over time. And then across individuals, there is also a large degree of variation. This has been recapitulated in other organ systems. For example, you can see the variation in the reference population from DOAR of stable heart transplant patients, as well as in stable lung transplant patients over time, again, between and within individuals. So because of this normal biological variation, it does suggest that the reference change value needs to be quite high. Some of the studies cited 50 or even 70% from the subject's baseline before you can determine the value is abnormal. One of the specific factors that seems to be influencing the intra-individual or within subject variation is actually time post-transplant. So this is a nice study where they looked serially at stable kidney transplant patients, sampling daily in the first 2 weeks post-transplant and then out to 1 year. And what's really apparent across all the studies is that if you sample too early, you're going to get a very high level of donor-derived cell-free DNA, whether you're using absolute or fractional quantitation. The same trend has been shown in heart transplant patients who are sampled very early post-transplant. This is one example from the Graft study published in 2021. And then pilot results from a lung transplant cohort, the Alamo study, showed essentially the same trend. In the first 1 to 3 months post-transplant, the values are high in stable patients. Another phenomenon that we see in these longitudinal studies is that after the first year post-transplant, even in stable patients, the donor-derived cell-free DNA tends to creep up. And so that suggests that there's another time-dependent factor besides just the very early post-transplant period. So this study followed patients over 5 years. They had over 300 stable renal transplant recipients. And after about the first year post-transplant, they started to see this fraction of donor-derived cell-free DNA creep up. Importantly, they did not see a change in creatinine or GFR. So when they looked at the absolute level or concentration of donor-derived cell-free DNA, this did not trend up. And when they went on to look at the total cell-free DNA, which is mostly recipient-derived, this actually showed the inverse pattern. It was trending down over time. And so taken together, what they concluded is that the total amount, or the denominator of the fraction of donor-derived cell-free DNA, is actually declining, probably with exposure to CNIs, because the white blood cell count also declined with the same pattern. So this leads to our recommendations and gaps in this area. There is good evidence that population values in stable recipients change throughout specific post-transplant intervals. So it looks like there may need to be different thresholds determined during these specific intervals, even in stable patients. This is true when using a universal threshold, but time will also be important for longitudinal surveillance. By serially testing a patient, you could determine a relative change value. However, because of those very early post-transplant kinetics, caution should be used when defining the optimal individual stable baseline. And more longitudinal studies would be very valuable to determine if this is helpful. Another takeaway from these studies is that there is a significant component of variability that's deriving from donor organ mass, which may account for some of the inter-individual variation. Again, this pilot study from the Alamo group showed that recipients of bilateral lung transplants had substantially higher levels of donor-derived cell-free DNA compared with recipients of single lung transplants. This was confirmed also by Keller et al., who further suggested that they could correct for this essentially by doubling the value from single lung transplant recipients to achieve a universal threshold that would be applicable across all patients. This is because they also observed that not only at times of stability, but also during rejection, the double lung transplant recipients had higher donor-derived cell-free DNA levels than single lung transplant patients. Conceptually, a similar scenario occurs in kidney transplantation, where pediatric transplant recipients may have a substantial differential in donor size. And this small but important study showed that children who received a kidney from a donor whose body size index was greater than 1.5 times their own had much higher levels of donor-derived cell-free DNA, even at stable situations compared with those who received a size-matched kidney. So this really gets to the question of, is my threshold and my detection of the analyte appropriate for my specific patient's population? Our recommendation is that reference ranges and the abnormal thresholds will absolutely need to be defined for different organs. But there are very few published studies that use the same platform to directly compare them. We're inferring this from the fact that the vendors have different thresholds for different organs, where notably the threshold for an abnormal result in a liver transplant patient is 20% of donor-derived cell-free DNA, compared to a kidney transplant patient where it may be 1%. There's also some limited but important data demonstrating that the size of the donor organ is going to contribute to the stable baseline level. And so a gap that we're identifying here is really to determine whether we need different thresholds or some kind of adjustment value for donor organ size. Lastly, we want to emphasize that there are specific clinical scenarios where the test may be unreliable or not indicated because detection of the analyte is confounded. So there are certain patient populations that will not be eligible simply because there's a confounding factor into simply detecting or deconvoluting the donor DNA from everything else that's in the circulation. And very interestingly, in AJT, just recently, there was a publication showing that even PTLD that is donor-derived can affect donor-derived cell-free DNA measurements. There are other unreliable clinical scenarios where interpretation should be used with caution. In particular, measurement of the donor fraction or percent of donor-derived cell-free DNA is influenced by how much recipient cell-free DNA is present. So as we saw with the longitudinal studies, when you have a change in the white blood cell fraction, you can have a change in the recipient or total cell-free DNA. So in settings of leukocytosis or systemic infection or leukopenia, or other interventions that affect the leukocyte abundance in the recipient, donor-derived cell-free DNA fraction will be less reliable. This is, again, reiterating that a known active infection probably is not the setting where you want to also test for donor-derived cell-free DNA to identify rejection. And then there are several studies in different organs demonstrating that this measure is elevated within 24 to 48 hours after you've biopsied. So it can be increased just from mechanical injury that is independent of rejection. So our recommendation is that there really is at this time that there really needs to be communication between the laboratory and the clinical program about which treatments and clinical statuses are ongoing at the time of testing, and to be sure to interpret the results with caution when there are these confounding conditions. Some gaps are that we need more data on the sensitivity of the assay under these specific conditions. So the lab can tell you how long after pheresis do you have to wait before you can test, for example. And we need clear guidelines on who and when not to test. We want to keep in mind that there are many non-rejection causes of elevated donor-derived cell-free DNA. As we saw with the serial sampling, proximity to transplant itself and probably ischemia reperfusion injury causes a high abundance of donor-derived cell-free DNA. But there are many other insults to the allograft that can influence this factor that have nothing to do with rejection. So this is an example of a sub-analysis of DART of patients who had BK viremia, and those who had BK nephropathy had very high levels of donor-derived cell-free DNA. Again, not rejection. Even in the liver, this publication showed that a subset of patients with acute dysfunction, but not rejection, had quite high levels of donor-derived cell-free DNA. So the value alone does not tell you what's going on in the graft. Because of this significant overlap in values, it really suggests that this test at this time is not specific for rejection. Conversely, no elevation may be seen in some conditions where the graft is being injured chronically or progressively. Thus, the negative predictive value tends to be reported as very high, but the positive predictive value for rejection is not great. And so this requires additional testing for diagnosis, again, similar to what is being used for NIPT, where it is not a standalone diagnostic test. So this is our recommendation at this time, that because of all of these confounding factors that go into the reliability of detecting the analyte, it is not specific for rejection. However, there are some studies suggesting that diagnostic specificity could be improved by integration with other biomarkers, or by really looking at whether the values are significantly different in different forms of injury. So we need more work, and the studies need to include different populations that are not just rejectors and non-rejectors. So to conclude, definitely donor-derived cell-free DNA is an exciting addition to our arsenal of testing. Minimally invasive monitoring has a significant advantage in patient quality of life and patient-reported outcomes measures, although these are not included in many randomized clinical trials, and we think that they probably should be. Theoretically, earlier detection of allograft injury with this biomarker could lead to an earlier opportunity for intervention, which conceivably could lead to better outcomes, although again, this has really yet to be demonstrated. And there's a potential cost reduction in post-transplant care compared with protocol or surveillance biopsies. However, we need standardization and harmonization across all of the testing phases to improve reproducibility, and that will enable assessment of clinical utility and meta-analyses. We also need clear guidelines to apply the principle of the right test for the right patient at the right time, and ensure that the testing is being done in patient populations where there is demonstrated analytic validity and the performance specifications match the patient population. And then we also need broad guidelines of what the changes in this analyte actually mean and do not mean to guide informed patient management. With that, I will thank you for your attention, and I look forward to the comments and feedback.
Wow, thank you, Nicole. That was excellent. I really I know it was the second time I've seen this, but I'm still learning a lot. I invite the other panelists to put on their camera for the discussion, and I also invite those participating, if you have any questions, please put them in the question and answer. One question I have, if you could comment, is on patients who've had a prior transplant, what considerations there, and not just there's maybe a kidney who's had 2 failed kidneys, but then what about patients who have had a heart or a lung and they have a kidney after and both organs are functioning? What do we need to keep in mind?
Yeah, what we found when we reviewed the vendor basically the vendor data sheets and indications for use, there are certain applications where they actually say you cannot test in regraft patients, and others where that's not an exclusion criterion. This is actually something, Roz was really bringing up, is that we need clearer guidelines on who we can test, because bioinformatically, I think it becomes very complicated to deconvolute donor versus recipient when there are additional bits of genetic material floating around. Roz, do you want to add to that? Or Roy?
I'm so distracted by all these great comments. So first, as a, I don't know what my role was, but I think Mike Mengel, who's not here, and I were, this was a topic I suggested to this group, particularly since I was understanding that these tests may be brought in to HLA labs, and you all have a very important understanding about lab standards and availability. So again, I didn't answer that question. There were some questions in the chat that are being posted that probably will tie into that. Maybe we could, I'm not running this, so I don't want to get in trouble, but I won't answer Howie's question, Dr. Gable's question, should this be in the lab as an HLA lab test? But one of the questions I can answer is there was a question about allograft size, and that's really not been looked at in terms, and how you would do that in a practical sense. Are you going to do ultrasound or CT measurements of the donor, or, if you have a living donor? But I do have experience with prior transplant, and certainly the baseline values are higher. They're higher because you have 2 kidneys from individuals. So I think what I learned from this working group is this longitudinal aspect is really important, and thinking when you're ordering this test, thinking about, is this person who's acutely ill, example CMV, and they have AKI, what am I thinking is going to happen with this? Because you probably will get a very elevated level if there's a lot of cell turnover. Did that answer or help?
Mm-hmm. Yeah, I think in our discussions, we really noted that there's variability across the current available modalities and whether they say you can test in regraft patients or not. And that's going to come from the pre-analytic and analytic variation and the methodologies. So it's really whether the deconvolution can handle all of that. Some of the modalities require donor and recipient samples for genotyping because that makes the deconvolution more reliable, whereas others are really just bioinformatically separating them out. So there's going to be variation, and I think we need guidance on that for each of the modalities.
Nicole, one of the things that I would like to hone on, sorry, Roy, I'll let you answer in a second, is a point that you've brought up that actually we can have different baselines for different patients. So that goes way beyond what a recommendation for a particular organ and so on and so forth. Did your group discuss some thoughts about how we can handle this? What would be recommendations for this, especially if that eventually will end up in whatever lab, but local lab that will do it? What should the clinicians consider thinking their labs that they need to do?
I think what we found is that there's, the population-based thresholds, there's good association, it's quite clear. But when studies started to use this reference change value, some % increase over some stable baseline, that seemed to have added value because of how much variation there is from individual to individual. What you introduced there is that some individuals may have, if you test too early, you determine that the baseline is too high, you know, so really the gap there is figuring out when is the true stable baseline. It may be somewhere around 3 to 6 months, assuming that they don't reject, but it's not clear yet. It does seem that there's value, but we didn't go so far as to recommend serial monitoring. And, you know, I think that the regulatory aspect to this and determining clinical coverage for testing as surveillance versus for cause is muddy, so.
Right, but a simple thing, if we're thinking of this as, okay, that's going to be a surveillance, we'll see something, we'll need to do something else. Are you going to recommend your patients, hey, don't have a 5-mile run before you come to see me? Because
right.
no, but those are simple, essentially simple things, but that can make really big difference. Those were things that when you presented for the first time, I was like, I'm like, I never thought of those things, but it really depends what your patient is doing before they're coming to see you. And I don't know that any of us thought about it before.
There's a question here
Roy,
about.
I think Roy was, sorry.
Oh, perfect. No, let's have Roy speak. He has a lot of
Not hear you,
experience.
Roy.
Oh, really?
Oh, we can hear
Now
you.
we can.
Yeah.
Not talking loud enough. I was just going to add to what's been said, but I mean, clearly, if you consider this as a longitudinal test, then you do have to be under the same conditions every time, which we know is physiologically impossible. So most likely, not only is it going to be time dependent, but there's probably going to have to be algorithms that take into account, you know, were you exercising? What's your white blood count? Did you have a fever? When was your last biopsy? All those kind of things that will actually give us some way of knowing how to integrate the information that leads to all this variability. So, and again, nobody's done that. Again, the issue of size of the donor and recipient mismatch, I think, is really an excellent point as well.
Deborah, I saw your hand up, and you have a lot of experience in this area too.
No, oh, can you guys hear me? Yeah, you can.
Yes.
I think there's two things too. I think the way practice is going now is, I don't know in the heart, but in the lung, some people are really looking at whether it should be done at least for them to get experience with it along with the surveillance biopsies. And again, we have to remember that if you have a biopsy, you're right after the biopsy, you do want to not take the biopsy right at that time because there will be some injury. And I think when you look at this also, we have to remember organ to organ, it's different. We in the lung have so much infection that it really can, it can be a little bit different than others. So it's much more frequent than probably kidney and maybe even heart. So I think when you look at it also, not just from the testing standpoint, but really when we look at testing in different organs, it's going to be different. And one last thing is when you look at the single versus bilateral, I think a lot of people have looked at that, and that could be used as a kind of a parallel to size in other organs, whether patients had a single versus bilateral, and that's pretty well been looked at by so many groups. So I think it helps with the other organs to know, hey, the depth or the size of the graft is going to change the way we look at it. Excellent review, Nicole. Just loved it.
Again, I'm just summarizing everything that everybody else who's experts in this brought up, and something I didn't get a chance to present, but I just want to emphasize is that clinicians are aware there is no external quality assurance program for this. There's no proficiency testing. Kelly, we discussed this a lot. It was beyond the scope for this presentation, but even just knowing that your lab is getting the same results as another lab, that needs to be established.
Before we're gonna go to Fadi, I want to take one of the questions from the chat. A lot of questions are coming up, and I'm trying to monitor both. But I'm really curious about the answer to this. So it looks like Kelly wants to answer this. Does anyone know how much of the cell-free, this is coming from Chris Sweeps, I'm sorry, how much of the cell-free DNA is from HLA loci? And does the degree of mismatch can alter the amount or type of cell-free DNA results that you're getting? So I think, Kelly, you wanted to answer this.
Yeah, thank you so much for picking this question. I love this question. So you could take this question one of two ways, actually. Do you mean how much cell-free DNA is detected by the assay that is specific to the HLA locus? Or do you mean how much shedding of HLA antigen cell-free, how much HLA relative encoded DNA is shed? So let me say that these are essentially chimerism assays. So they are not focused on HLA loci. There are actually, I haven't seen the contents of every single available vendor panel, but I can say that there are at least 2 vendor panels that do include some HLA loci in this, but it's extremely minimal. So this would probably not be contributing largely to the assay result that you see, but it's a wonderful question. I love seeing it.
Yeah, there's so many great questions. We have another great talk. So what we're going to do, just to make sure that we get through the next talk, keep putting through questions if you have them, but we are going to move to the next talk. If we have additional time, we'll work through these questions. We'll try to answer some of the questions live if we can, but we'll also, after the meeting, answer those some of these questions if we can. So great interest, and we'll just move on to innate immunity, and if we have time, we'll answer more of these questions, if that's okay. So I'm going to introduce Maarten Naesens. He's coming from Leuven, Belgium, and he has a talk about innate immunity, the potential role of innate allorecognition in kidney allograft damage.
So thank you so much for this introduction, and I feel very sorry for interrupting the discussion on donor-derived cell-free DNA. And I really hope that we can, after my presentation, also go further in this discussion and perhaps also tie in some of the things I will talk to you about. So my presentation will talk about the potential role of innate allorecognition in kidney allograft damage and how the STAR working group looks at this topic. So I have no relevant financial relationships to disclose, but I will discuss off-label use of daratumumab in my presentation. The classic paradigms of allorecognition, of course, focus on one hand on T-cell mediated rejection, on the other hand on antibody mediated rejection. We have many drugs that have been developed to shut down these allorecognition pathways. We know these pathways very well in our field. But what we start seeing is that when we diagnose, for instance, T-cell mediated rejection, some of the rejection cases are full of T-cells, as you would expect, but others are full of monocytes, which you would perhaps not expect. And what we see in populations is that patients with T-cell mediated rejection sometimes have biopsies that are fully composite by monocytes, others by T-cells, and it's really heterogeneous within the patients having all the same diagnosis. And the same is true for antibody-mediated rejection, where also some cases are full of monocytes, other cases are full of T-cells, and there is heterogeneity as well in the expression of NK cells. In a less hypothesis-driven research, we last year published a paper where we looked at single-cell RNA sequencing data of kidney transplant rejection biopsies. And what we found is that there is a strong association between the inflammation by NK cells and myeloid cells and the rejection severity as assessed using the activity index, all highlighting the role of innate immune cells in the rejection phenomena. The relation between T-cell activation, B-cell activation, antibodies, and NK cell activation has been demonstrated, of course, also very nicely by many studies in our field. But what is perhaps not that much studied is whether these innate immune cells could be activated without the primary allorecognition by T cells and B cells, so independent of these more classic paradigms of allorecognition. And that's, of course, the topic of my presentation. So first, NK cell allorecognition. I will not go into much detail on the biology of NK cells, which is quite complex, but to make the complexity a little bit more simple, the NK cells are kept in balance and kept in resting state by a balance between activating and inhibitory receptors. And in humans, the major inhibitory receptors or the killer cell immunoglobulin-like receptors, the IKIRs. And they interact with MHC class 1. And when you have a nice balance between the activating and inhibitory receptor signals, the NK cell stay resting. In oncology, for instance, tumor cells try to escape the immune system by lowering the expression of HLA molecules. And this can lead then to missing of these HLA molecules by the NK cells. And the imbalance between the activating and the inhibitory signals of the NK cells then can lead to NK cell activation, so a kind of secondary defense mechanisms against cancer. In transplantation, of course, we do not have downregulation of HLA molecules, perhaps even the opposite. But what we can have is a mismatch between the donor and the recipient in MHC class 1 molecules. And this mismatch can lead to a concept of missing self. I will explain that a little bit more in detail in the next slide. The KIR receptors are not universal and in the population. So there is heterogeneity in the presence of KIR molecules, and this is genetically defined. Also, of course, we know that there is heterogeneity in the population in the HLA class 1 genotypes, and the NK cells that get activated by missing self. They need to be educated, so a certain KIR receptor needs to have seen a certain HLA class 1 antigen before the NK cells are educated for that specific HLA antigen. And so when you now enter a donor organ that does not have this specific HLA class 1 molecule, then you have a situation of genetic missing self. And this is biological knowledge that is already quite old. It's not that new, can be genotyped easily in a population. But when we talk about missing self, it's clear that you need to assess not only the HLA class 1 molecules of the donors and the recipient, but you need to take into account also the heterogeneity in the KIR receptor genotypes in the population. So with these concepts, Olivier Tonat and the team in Lyon who started thinking about how this could be translated to kidney transplantation. And they looked at patients who, in the absence of donor-specific antibodies, developed microvascular inflammation, and other patients that did not develop microvascular inflammation after kidney transplantation. And they could demonstrate a significant association between the number of missing cells and the risk of microvascular inflammation in this kind of case control study. They then went further and looked at what are the whether this could be reproduced in vitro, and indeed, when there is missing self with education, as I explained, of the NK cells, this is sufficient to lead to in vitro activation of these NK cells. And then in elegant in vivo studies, they could demonstrate that when you knock out beta-2 microglobulins, so with mice that do not express HLA class 1 molecules on the surface of the cells, that transplanting such hearts can lead to inflammation by NK cells in the microvasculature, so again, MVI. But what was noted is that this missing self is not sufficient, but that there needed to be kind of second hit ischemia. And that is also something that is known in NK cell literature, that education on its own is not sufficient, but that you also need priming of the NK cells. And this could be done by ischemia reperfusion. We took the concepts and the paper by Olivier to a population level, and in a relatively large cohort of kidney transplant patients, we looked at whether the number of missing cells associated with the risk of microvascular inflammation, and this association, as you can see, is relatively strong. And in a very recent analysis on the cohort in Basel, they could show exactly the same significant association between the number of missing cells and the risk of developing microvascular inflammation after kidney transplantation. it's even more interesting to see that the missing self is independently associated with microvascular inflammation of donor-specific antibodies, and even more, when you have both missing self and donor-specific antibodies present, the risk of microvascular inflammation is significantly higher. So these risk factors seem to have a cumulative effect. When you have only missing self or only donor-specific antibodies, the risk of MVI is significantly lower. And this was confirmed in Lyon, where they demonstrated that when you have donor-specific antibodies with missing self, that the outcome of the kidney grafts is significantly worse than when you do not have missing self. Is this relevant? Yeah, I believe it's more and more relevant because, for instance, very recently it was demonstrated that NK cell inhibitory therapies like anti-CD38 therapy, felzartamab, was efficacious in shutting down the AMR in a large proportion of patients. And when you stop felzartamab, the AMR came back in quite a number of cases. This is, of course, targeting the NK cells in the context of DSA positive rejection. But what was very interesting to learn at the last bench meeting just a few weeks ago is that the same team also have treated a small number of cases of DSA negative microvascular inflammation, so cases where the inflammation is not explained by DSA, with NK cell targeted therapy, daratumumab, and that they found also a very good effect of this NK cell targeted therapy for this phenotype, illustrating that it might be really relevant to find out whether our patients have a causal relation between, for instance, missing self and post-transplant phenotypes. I promised you to not make things too complex, but I don't keep my promise. What we are discussing now is only part of the activation mechanism of NK cells, antibody-dependent cellular cytotoxicity on one hand and missing self on the other hand. But there's many other mechanisms that are known to play a role, like the binding between NKG2D and MIC-A, MIC-B, and also other concepts of pseudo-missing self, NKG2A activation, NKP44. All of this is not studied in the field of clinical organ transplantation. And so when we talk about missing self as a concept for NK cell activation, maybe the genetic prediction of missing self on its own, as I said, by genotyping the KIR and also the HLA class 1 molecules, is a little bit reductionistic. Thinking solely about missing self, we have to take into account that there is a heterogeneity in the expression of the KIR molecules on the cell surface of the NK cells, and that also the number of NK cells is highly heterogeneous. And this is not taken into account in our genetic definition of missing self. And we do not also consider at the moment in most of these studies the fact that the NK cells need to be primed. And this can be by ischemia reperfusion injury. Also, viruses can prime the NK cells. So we might need to tie all of this into our future studies. And finally, we do not consider polymorphisms in the inhibitory and we know that these have impacts on the signal strength. So missing self defined solely based on the genetics of the donor and the recipient is perhaps a little bit too simplistic. And as I said, many other mechanisms of NK cell activation have not yet been studied in detail in clinical studies. And for instance, we have in the working groups quite some discussions on whether we should more emphasize also haplotyping and the KIR, not only the inhibitory KIR, but also the activating KIR, because, for instance, in hematopoietic stem cell transplantation, it has been demonstrated that this could play a role in the prediction of graft versus leukemia effect and so outcome of the patients. So how can we bring this concept of missing self towards ultimate clinical utility? That's what we start thinking about in the working group. And I think that the first thing that is really important, and I hope I convey this message, is that we should all embark on the same definition of missing self, for instance, genetic missing self. As I explained, by genotyping the inhibitory KIRs together with HLA class 1 molecules. But we also need much larger studies that assess the specificity of the association between missing cells and microvascular inflammation. And these larger studies should not only come from Europe. I think there's really a call to have studies also from the United States and from much more heterogeneous populations than the relatively homogeneous European populations that have been studied until now. And what we, for instance, need to know is how many of the cases that are DSA negative but have microvascular inflammation could be explained by missing cells. And the reason to study this is that we really want to see in which cases would it be relevant to analyze the inhibitory case, or should it be done in all cases? All of these questions have not yet been discussed in any of the studies that have been published until now. So let me move now to the second part of the presentation, a little bit a smaller part about monocyte allorecognition. And in the literature, there's quite some nice studies that have demonstrated that in animals that are deficient of T, B, and lymphoid innate cells, macrophages can recognize and reject allogeneic tissues. This is strong basic research that has been published over the last 15 years. But more recently, it was discovered by the team by Fadilakis, who is also a member of the working group, that this could be explained by the binding between SIRP-alpha and CD47. In normal circumstances, the monocytes or in resting conditions do not get activated because the positive signals coming from CD47 are kept in balance by the negative signals from SIRP-alpha. But enter a foreign cell from non-self, it can be that the SIRP-alpha from this non-self has a higher affinity for the CD47 of the monocytes, for instance, because there's polymorphisms in the SIRP-alpha. And this has been demonstrated in this very elegant study to lead to activation of the monocytes and maturation of these monocytes into dendritic cells. In later studies, the same team then demonstrated that when you have upregulation of activation of the monocytes by the SIRP-alpha CD47 interaction, this leads to upregulation of PIR-A, its paired immunoglobulin-like receptor A in mice. The human counterpart is LILR, the leukocyte immunoglobulin-like receptor, that these receptors get upregulated, and these receptors, they can bind to MHC class 1 molecule in an allospecific way. And when you have this, this can lead to the development of memory monocytes that then on their, in turn, again, interact with the monocyte-derived dendritic cells from the monocyte activation through to the CD47 SIRP-alpha pathway. So relatively complex biology that has been demonstrated to be very robust in preclinical research. The question for the STAR working group is, how do we bring that now to clinical relevance? And let me now take again this study published last year, where we demonstrated how the myeloid cells are significantly associated with the severity of inflammation. And then when we look at these myeloid cells more in detail, the single cell studies demonstrate that in the context of rejection of inflammation of these grafts, there is an upregulation of LILR receptors in these myeloid cells, suggesting that indeed in humans this machinery is present and is heterogeneous in the post-transplant kidney biopsies. Another piece of the discussion is that we know that also in humans, as it is in mice, there are SIRP-alpha polymorphisms, and there's at the moment 13 haplotypes that have been described in almost 90% of the population. The top haplotypes can be divided in two groups. You have V1-like and V2-like haplotypes, and they are related to the absence or presence of a deletion at a position in 99 of the SIRP-alpha gene. And what is very important is that there is nice data on human cells that the V2 haplotype is associated with high affinity for CD47, while the V1 haplotype is V1 alleles or have lower affinity for CD47. So in humans, there is the possibility that these different haplotypes have different affinity for CD47 and could lead to the same mechanism of monocyte activation as was demonstrated in preclinical models. Is this now true in human clinical studies? Well, in hematopoietic stem cell transplantation, it was demonstrated that indeed, when you have a CYP-alpha mismatch, there is a significantly increased risk of graft versus host disease, and of course, related to that, significantly better outcomes of the patients who are CYP-alpha mismatched. And in kidney transplantation, the team of Anat Tambur demonstrated that in HLA identical living donor kidney transplantations, the numbers are relatively low, but in this HLA identical transplantation, when there is a CYP-alpha mismatch, there was a higher rate of graft failure in comparison to patients that had, or transplants that were CYP-alpha identical. This did not reach statistical significance, but you will agree with me that these curves show an intriguing trend in line with the hypothesis. Even more recently, and this is still unpublished data, a combined cohort from Pittsburgh and Lyon demonstrated that transplanting of the B haplotype of the V2 alleles into A or V1 humans led to a highly significant increased hazard ratio for graft failure. And you can appreciate that this rate is in the same order as the association with de novo donor-specific antibody formation. So quite striking finding in this combined cohort. And then in Pittsburgh, in the sub-analysis of the biopsies that were performed within the first year, they could demonstrate that this is related to a higher rate of T-cell mediated rejection, so inflammation in the tubular interstitium. To summarize the second part of the presentation, the proof of the concept of monocyte allorecognition is very strong in preclinical models, and we start seeing the translational potential CYP-alpha polymorphisms present in the population, little overexpression in the context of rejection, and we are starting to see some clinical association studies that all go into the same direction. But it's obvious that we need much larger scale observational cohort studies to demonstrate really the clinical validity of these associations. And for instance, also the relation with rejection to interstitial inflammation and outcomes. And one thing that is still very unclear is, for instance, how the CYP-alpha polymorphisms relate to these outcomes in relation to other known risk factors. And this hopefully illustrates that we have very strong preclinical and clinical suggestion that both missing self and myeloid allorecognition could play a role in the rejection phenomena that we observe after kidney transplantation and perhaps in allograft outcome. But the question is, how can you bring this then to clinical utility? And I adapted this slide from Carrie Schinstock, where she demonstrates that from a discovery and hypothesis to clinical utility, you need to put many steps. First, you need preclinical validity of the hypothesis. When we talk about lab tests, for instance, the evaluation of missing self, CYP-alpha genotyping, the analytical part also needs to be validated. We need clinical validity to demonstrate that missing cells, that monocyte allorecognition pathways are indeed clinically relevant in routine conditions. And then finally, we need tests to demonstrate clinical utility, whether implementing such tests in clinical practice actually improves the outcomes of the patient or lowers the costs or other things. When we then translate this framework to the field of innate allorecognition, I hope that you will agree with me that the hypothesis is strong, based on strong immunological insights, and that's specifically in the field of transplantation. We are seeing now the translation of these concepts to strong basic preclinical and translational research projects, so that both the discovery and the preclinical validity are quite strong. I showed you several studies that suggested clinical validity, but I also mentioned that we need more larger observational cohort studies to demonstrate how much these concepts of innate allorecognition contribute to the phenomena that we see post-transplantation. But we still need further validation. We need more discussions on the analytical phase. How do we analyze missing self? Should we take into account, for instance, the genetic, the differences in expression of the KIR molecules? All of these questions have not yet been discussed even in the literature. And finally, before we can embark on promoting the testing of CERP-alpha in routine clinical practice to test for missing self in routine clinical practice, I hope you agree with me that we need studies on the clinical utility. And with that, I would like to thank, first of all, the members of the Innate working group, the coordinators of the STAR initiative, and all the other STAR working group members for their enthusiasm to work on this project. And I hope you enjoyed this presentation. Thank you very much.
Thank you, Maarten. A great talk. Again, I invite the panelists on this. We'll start out with the discussion about the innate immunity, and if we have a little bit of time, we can continue talking about cell-free DNA. One of the questions from the audience was, and this is a basic science question, so others can answer as well, is the presence of infiltrating CD56 positive cells on the allograft biopsy sufficient to suggest NK response, or do we have to do stain or look for other activation markers?
This is a very good question, because at the moment we discuss the causal. Can we assess the genotypes, for instance, to see whether the donor-recipient disparity gives us hints? Of course, there should also be a place for the staining of biopsies to see whether the NK cells, for instance, are there. And the fact is that most of the AMR cases have NK cells, so the NK cells are quite present in the AMR. But there is, as I illustrated in one of the first slides, a lot of heterogeneity, and we do not know why there's such a heterogeneity in the composition of the immune cells. We don't know whether that is actually related to the underlying genetic disparities between the donors and the recipients. But I would guess that, for instance, when you want to give NK cell inhibitors, that ultimately it could be relevant to assess not only the missing cell, but for instance, also how much infiltration is there in the biopsies. All of these are very relevant questions, but I don't think that they have been answered at all in literature. And the CD38 studies that are inhibitory studies that are being launched now, hopefully will look into this kind of questions, because they could give us predictive biomarkers for in which cases and in which specific circumstances which drugs work. I think it's a valid question.
Fadi, you have your hand up. Did you have additional comments?
Yes. Thank you, Carrie. So I just wanted to first congratulate the European groups in Lyon and Leuven and other places for doing this fantastic work. It was about time. And I would like to make a proposal, a provocative one. I think it is time to drop the ABMR nomenclature. It is misleading and incomplete, and maybe we can have nomenclature that says MVR, microvascular rejection, and acknowledge that there are multiple pathways that lead to this lesion that contributes to chronic rejection. I think the ABMR bandwagon has run for too long, and I believe to be provocative quite erroneously. So that's my appeal to the community. Thank you.
There are several questions asking about effects of immunosuppression on NK cells. What do we know about this? I see that Olivier is starting to answer some of those. Do you want to kind of combine all those questions and answer them together, maybe?
Yeah, sorry, I was trying to save some time because I realized last time that in the previous presentation that we didn't have time to answer to everything. So I was making sure that everybody would get some
answer. That's fantastic. If you just share everyone.
I think that the question by Anita was whether CNI had an impact on NK and monocytes. So monocytes, I will let Fadi answering this, but for the NK, what I can tell is that All the patients that developed this missing self presumably induced microvascular inflammation because they didn't have DSA. They were on CNI. And in the mice model, we compared the impact of no drug, CNI, which was cyclosporine, and an mTOR inhibitor, and only the mTOR inhibitor had a beneficial impact on the MVI, and CNI didn't. So I suspect that on NK, they didn't seem to have any impact on this process.
There was a question earlier in the Q&A just about how local labs, how easy it is to check for, some of these mismatches. Can someone comment on that? I think, Nicole, you had talked about that earlier.
I typed in the answer and didn't
Oh,
realize
no.
take it away. So yeah, so the question was, I think, if how can labs do this HLA ligand mismatch assessment? And it's something that we already discussed as a group, which is many labs serve stem cell transplant programs. And so in the setting of haploidentical transplantation, this is a risk assessment or donor selection criterion. So we already have KIR genotyping assays up and running in many HLA labs.
But then the question is, oh, I'm sorry to interrupt. Someone was speaking. But then I think the question is, should we, and in what settings? And
No,
that gets more complicated, right?
Yeah, that's it. That's exactly it. So in the discussion that we had prior, the HLA lab say we can measure all of that, and also CYP alpha genotyping is not that complex. We don't do it in Leuven, but what I learned from Fadi and from Olivier Tonat and from other people who have done it, it is something that you can implement relatively easily. But we of course should be very careful to not implement things that we don't know how to interpret and that we jump to conclusions far too quickly, because this could, instead of helping the field, kill the field. And I think we have to be proceeding. And I think this kind of sessions is really important, because I hope that many people get enthusiastic about these concepts. Basic immunologists, translational immunologists, all are very, very interested in this concept, but we need more clinicians interested in this field, collaborate and see how can this be translated into clinical utility. And this requires perhaps completely different framework than what was done at the moment. And in addition to that, I think that Olivier will agree with me that we need to also go back to the bench. So what we see in the clinics, what we observe, needs to be taken back to the bench, because we know that, for instance, in NK cells, there's so much things that we still don't know, that just thinking that missing self is going, and the genetic definition of missing self is going to solve all our problems is nonsensical. There's so many other things happening at the same time that we need to be very, very careful to not jump to conclusions too quickly.
Yeah, I mean, as Maarten said, more studies, more population studies are needed for both the missing self, the KIR mismatch, as well as for CERP alpha and other allorecognition in the innate system. But many of them are ongoing now. So I think I agree. We should wait till those studies are out before these things are implemented as clinical tests.
It seems like some of our participants are unable to put their questions in the Q&A. So I'm trying to monitor the chat, but maybe Roz, if you can help me and actually convey the question.
Yeah, so I asked a question because I can't get into the Q&A. I think a panelist is blocked. So a couple things. One, I appreciate this notion of NK. Maarten, you know why people are excited? It's because things haven't worked to date.
Mm-hmm.
So Fadi's point about nomenclature, we're attacking antibodies, we're attacking B cells, we're attacking plasma cells. So here is something that sort of fits, sort of seems interesting. It's not new, it's been going on for almost 10 years, but we're so much closer. And so I think that's the enthusiasm that you and Olivier are sensing, because that's how I sort of have this long perspective. The question I had actually goes to the prior presentation. As we see HLA labs pulling in these tests, the cost is quite high right now. So the way CMS can compensate It's 2,800. You can bill it. You may not get paid, but that was derived from Medicare, Medicaid, the notion that you wouldn't do a biopsy if you did a test and it was negative and the high negative predictive value. So I think, Kelly, you had offered to answer that question.
Yeah,
Maybe.
and I'm going to try to be really balanced in my answer. Because we obviously are validating this in our lab and we're using a certain modality. So I'm going to try to leave that out of the picture and just say that I think laboratories do have options with the test method and modality that they choose. Some of those modalities have more or less markers associated with them. Some of those modalities involve different equipment, different analytical software, different turnaround times. All of that impacts cost, right? I do think there is thought to be had about the cost of having a test available in-house versus sent out to a vendor to think of as well. And I think I saw early in the chat that Howie Gable asked a similar question: should HLA labs even be doing this based on the data that we have currently? So I think there are cost differential options, and that every lab, depending on the volume of this testing that they'll be performing, needs to look into that for themselves. Right now in the US, a generic CPT code is applied to these, and you can use that CPT code and charge as much as is applicable to the test modality that you're using. Mm-hmm. So you could use a cheaper test modality and not charge $2,800, right? So things to think about that would impact cost.
I think, James, you had your hand up. Did you have something to add there?
Yeah, I was going to add to Kelly, and this is more of a Canadian perspective. The way we're being funded for our testing is by jurisdiction, in our case, by hospital. So if there is enough data to demonstrate clinical utility, then the hospital consider it. But cost for us is going to be, can we do this as a decentralized test? And so when I've spoken to vendors, even the most expensive one, which has been billed as, $3,000 US, could come down to the price range of a DSA test if run locally. So I think that's what we're working with, and I think that has been acceptable to our hospital. But the issue becomes a laboratory issue, is that you have all these different labs now running their own tests. It is a kit sold by the vendor, but are these results comparable to a central laboratory test? That is the question. So we've now almost completed validation, and we're going to invite more labs to do this. It's a two-way validation where we test the same sample, the reference lab will test it, we will test it, and do these results agree? Because unless we do something like this, then each lab will have to tackle the clinical utility question in their own jurisdiction, which is very challenging to do because you need large patient numbers and cost to do that. So at this point, we're hoping to show our data in our hands are the same as a reference lab, and therefore we can serve as a lab to deliver that result at a cheaper cost.
And I'm just going to throw one thing in before I go to donor. I thought Nicole and the group did a good job, because until I embarked on this project, I didn't have a good sense that these tests all have different thresholds and all have different baselines. And so I see groups using one versus the other. And I just got an email from Eurofins that they have a mega panel with TrueGraph and cell-free. So you have gene, cell-free, and now viral monitoring that you can do all in one sample. So the notion is you can just sort of, you have somebody in that's not feeling well, graft dysfunction, whatever, and you can get an pull all sample from one tube. So I just think that, we need to be thoughtful as clinicians in how we're addressing these things and not mislabeling patients. But I think those slides are really important.
Yeah, I'll just add to that, Roz, is I know it sounds really boring to talk about proficiency testing and quality assurance, but, Kelly really delved into the NIPT literature because they had big challenges trying to establish external quality assessment. And we can learn from that. And even one of the studies that was published recommended that until there's standardization and harmonization, individual labs need to have their own thresholds and ranges, which is kind of a disaster when you're trying to establish clinical utility, because now you have 200 different labs with 200 values being reported.
And it seems to me that we're kind of coming in this crossroads at an awkward time because there's more and more data from the centralized labs, but this is the same time that it's coming from local labs, right? So I can see the scenario where clinicians are reading some of the literature, which there's limitations to the literature, but get really excited and then start implementing it in their lab, and it's not going to work. I mean, so I think that really needs to be emphasized, and that idea of proficiency testing is very important.
Yeah, to be clear, we're not naysaying any of
Right, right.
thing. There's a lot to think about while doing this, and moving the field towards standardization and harmonization of desensitized tests now before everybody's run with it and already has their protocols established is something to think about.
And again, I think one of the ideas from a clinical perspective is, okay, cost is important, but turnaround time, even, because when we all order HLA antibody testing, the turnaround time is very predictable, very timely to the time of a biopsy. So I think that notion was one that from a clinical perspective would add to the practical nature of using these tests.
Deborah, you had a comment.
Oh, yeah. Hi again. No, I think we're talking even when above and beyond even clinical work. If we talk about multi-center trials, even looking at, I'm thinking about a study that we did with DSAs in lung, and just trying to get all of us on the same page about what we're calling a cutoff. And that's basically, was very difficult. And I think even when you talk about now multiple assays, different labs, if it's intra-lab, it will maybe even make it a little more messy. So I think it's a great thing that you're doing this to get this established, so even both for clinical and research purposes.
Yeah, and I think in a way, the discussion has moved, that sort of came up a little bit earlier, but instead of using it as a surrogate for another test, it's now being used as a way to justify doing additional testing. So it's kind of that the intended purpose has not been met, despite the fact that we don't even know how to use the test yet. And again, I want to emphasize that this is not because I think anyone on the panel thinks it's a bad test. I think everyone thinks it has tremendous potential. We just need to know how to use it.
There is another question in the Q&A chat here that I want to direct again into to the innate immunity group. Since more studies are in patients with European background, how do we think the data are affected by the racial polymorphism in different populations with different ancestry? And I see, Fadi, that you had put something in the chat, but I think this is an important question that I would like to make sure that we are sharing with all our audience. So if you don't mind answering this, or anyone else from the innate immunity group.
I'll let the NK experts answer, maybe Olivier.
No. I was when no, of course not. I mean, when Anna started to set the question, I knew that you would answer very well, because you have been challenged by that for the monocytes.
So basically the answer is not known. And I think that's where, again, the emphasis on doing these multi-population studies. So for example, Olivier and I put a grant into the NIH to do exactly that, looking at European as well as American populations, one on the West Coast, one on the East Coast, with a good diversity of minorities in it. So the answer is not known, and that's why the NIH is so interested in having people sequence patients from diverse backgrounds.
But Fadi, maybe you could comment on the fact that one of the comment of the reviewer was that CRP-alpha CD47 mismatch that you were describing in monocytes could be someone linked to the racial disparities of the donor and recipient's pair, and you were able to really rule out this hypothesis. So I think this is also a piece of information that is important.
Well, I think unless there are additional questions that I'm not seeing, Carrie, maybe it will be a good opportunity to remind our audience that there will be an in-person meeting. It would be the morning just prior to CEoT. So what we're planning on doing is taking all the questions that we've received in those 2 webinars. I will put in a chat in a minute my email address. I've invited people who did not get an opportunity to put their questions during the webinars or will be listening to the webinars not through the recordings, not in real time, to send those questions in. The STAR working group is really interested in getting your opinion so we can think about it and consider this as we're coming up with our final recommendations. And I will encourage everyone to come to CEoT and together with us have the opportunity or the benefit of being part of the STAR process. With that, Carrie, I'm gonna
give
it back to you.
And I also want to, thanks Anat very much, and thank you again to the speakers, to the panelists for an excellent presentation. I also just want to say that this year's STAR, we're looking at not just our formal meeting report after the meeting, but the working groups are also working hard on companion manuscripts so that they can be include more than just what has been presented at the webinars. So really trying to expand that and let you know about that. But thank you again. And if questions were not brought up, please reach out to us, and we really want to know things that we might be missing, right? And also get your clinician friends involved in this, because I think that's the integration is what's really critical here. So thank you. We'll let everyone go and look forward to seeing you in. Oh, did Brian have? Yes, thanks. Brian has some closing comments.
Thank you so much. We would like to thank our STAR Working Group presenters, moderators, and panelists, and all of our attendees for today's webinar. The STAR Working Group would also like to thank AST, ASHI, Mark Terasaki, One Lambda, a brand of Thermo Fisher, and Imokar Werfen for their continued support. After the session closes, please take a moment to fill out our evaluation survey link to help keep our content current and engaging, and to help the STAR Working Group prepare for CEoT 2025. Thank you all again for today's session.